Hmm. Hello everyone. Once again, welcome to our MRCOG3 MADC. As I told you, we are presenting the stations for you to make you to give you an idea about how to present. So today I'm going to today I'm going to tell you about the two stations. One is the risk management, that is very important. And risk management can come as an any station, any scenario. So here today I'm going to tell you about the acute kidney injury. Then after that I'll talk about the contraception. So now this is the station which is in front of you. So this is a structured discussion task that assesses the following skills. Always these are the skills which are assessed. Then that is information gathering, communication with colleague, and then patient safety, applied clinical knowledge. So here the scenario is like this: you're an ST5 on call, taking over at 8 hours morning. So your colleague, junior colleague, wants you to see a first post-operative patient who had an elective cesarean section planned section before the DCD18 at 38 weeks for preeclampsia. And it was actually scheduled in the morning, but it was done in the evening. So there was a lot of delay. And after 15 hours, she developed a fever and was seen by the junior colleague, and he noted the temperature. It is higher side, BP is falling, pulse rate is tachycardia, and sepsis protocol. Because of these signs of sepsis, so he started the sepsis protocol. So the investigations have been sent, and initial investigations are showing that hemoglobin lower side, WBC is slightly higher side, potassium and GFR also, and creatinine, all these things are there. And the said tests are repeated. So the tests are repeated, and repeat blood tests are there. So WBC showing signs of sepsis. So that now how the exam is in front of you. So he's going to ask you questions, and because questions are here displayed, but in the exam they are not displayed, he will be asking you. So these are the questions we are asking you today, we are showing you, but it can be any question. He can ask twist the question also. So now how we are going to start? I'm going to start now. Hello, I'm Manjula, part 3 candidate. I'm ready to proceed with the, as I went through the case scenario. I'm ready to proceed with the case discussion. So this is what you are going to tell him. So then he will say, summarize. So he may say you to summarize the question, summarize, or he will say, tell me about what is the diagnosis on the basis of the interpretations. So this is what the examiner is going to ask you. So now you say, thank you for your question. Always you say thank you for the first question. And then now you say, I can see the woman under discussion is a post-operative patient already seen by my junior colleague. In terms of interpretation, I can see her pulse rate is increasing, there's tachycardia, there's a fall in blood pressure, BP is falling, temperature is increasing. So, and then creatinine, coming to the investigations, creatinine is rising, GFR is falling, the glomerular filtration rate is falling, and it appears from that the kidney is involved. So, apart from this, I can see her CRP, that's so C-reactive protein is a higher side, is increasing. So WBC count, they are increasing. So both are increasing, giving a picture of sepsis. So kidney involvement is there and sepsis is there. So I am suspecting evolving acute kidney injury because of sepsis. So kidney injury, the causes you need to know. Now this is the interpretation. We are interpretation, and on the basis of the investigations given in front of you and clear scenario, you are going to give the interpretation. Now the other questions examiner is going to ask. Second question is, what will be the initial management? So you say patient is having hyperkalemia, which is a medical emergency. So I will assess my patient. So I will inform first. Initially, I'll inform the consultant about this patient. I'll review her notes, and then I will proceed with the ABCD approach. So, and that is assessment of the airway, breathing, and circulation. So I would like to check her hydration, and because of the hypotension, it is a pre-renal cause of acute kidney injury. So I will correct the hydration and dehydration. I will correct it by giving IV fluids, and then I'll check her chest for any this is the examination for any kind of infection, whether she has any chest infection. So then I will move on to the abdominal examination. Then I will check because she had cesarean section 15 hours before. I would like to check her wound. So, and look for any distension, guarding, and bowel sounds, tenderness, and renal angle tenderness, and also look for the bowel sounds. Then I'll arrange for the investigations which are not sent. So I will arrange And this is no sometimes the repeat investigations, or if the investigation have been sent, I will ask for the reports which are here. The repeat investigations are in front of you. So that is the full blood count, the renal function test, urea electrolytes, lactates, and CRP, which are there in front of you. As per the patient is having chest symptoms, then we need to go for the if there are, we need to go for the chest X-ray. And because she has hyperkalemia, the potassium is on the higher side, I would like to ask for a ECG and also a renal scan. All these things is to know the source of infection, because she's showing signs of sepsis. So because of the sepsis, signs of sepsis, I would also advise to ask for a blood culture, urine culture. And then the further management depends upon. So then we will upgrade, because we'll, first of all, we need to upgrade the care for immediate management. That is, shift the patient to HDU, high dependency unit, and also or intensive care unit. And then it is a multidisciplinary approach. So so I will be involved in the multidisciplinary team, which especially our consultant, whom I already informed, and the critical care team will be involved in this case. Then renal physician and microbiologist, all of them are involved, along with the senior nurse and lab technician. They are involved. Then I will look for the hydration, start the IV fluids, get the access, start the IV fluids, and strict input and output chart we have to maintain. Then we continue the observation, that is frequent, that is a more early obstetric warning chart. We will continue observing the patient and make sure patient is not getting any nephrotoxic drugs. So we need to check her medication chart and see whether she is getting any nephrotoxic drugs, that is non-steroidal. Usually we give painkillers like non-steroidal anti-inflammatory drugs. If anything is there, we need to stop it. So see the medication chart. Now patient is still has hyperkalemia. If patient still has hyperkalemia when we repeat the blood test, then she is reviewed urgently by the medical team. Depending upon the depending upon the ECG findings, we will consider her giving the calcium gluconate. We have to treat the hyperkalemia. So then correct the hyperkalemia. Now I will check the patient's blood group, because she is having hemoglobin on the lower side. I'll check the blood group, patient's blood group, and whether there is any she is any Jehovah's Witness. So I will ask for any her opinion about the reservation blood. So then I will consider blood transfusion if she depending upon the situation. So now I'll the patient blood group, as the hemoglobin is this thing at present, I'm not considering blood transfusion because it is 8.2. So I'm not considering now. And I will look for the sepsis bundle, whether it started. Already the sepsis bundle, if it is started, that means we give the IV fluids. It is already started. We give the IV fluids. We give the broad spectrum antibiotics and oxygen if the saturation is low. Then we take the blood sample already sent for your culture, urine culture, and lactate, and then urine output chart. So this is the sepsis bundle, which is already started. Now I already reviewed her notes. Then antibiotic change, and after checking the allergies, then I will also assess the risk of venous thromboembolism, and depending upon that, whether she needs anticoagulants or not. Now we continue keep the monitoring the patient, continue this management, and if patient does not respond in spite of all this, we may have to consider discuss with the renal physician, involve the renal physician, and go for the renal replacement therapy. So this will be the initial management. So then pause. So then the examiner will ask you, what are the factors responsible for this case? So you say, first I would like to gather information and that symptoms, whether she has any symptoms of any nausea, vomiting, any weakness, any lightheadedness, or any pain, and what is the blood loss, whether she is still hypotensive. So I would like to review her postoperative details. Then I will check her fluid status. I will check her early warning chart, score chart, and then amount of fluid she got, how much of fluid she got, and whether she is still getting nephrotoxic drugs, which are all reasons for the hypotension, nephrotoxic drugs, all are the reasons for the kidney injury. So I would like to rule out all these. So I would like to check her fluid status, amounts of fluid, whether she got adequate hydration, whether she's still getting nephrotoxic drugs, and I will check her urine output also. Then preoperative details. I would also go through the preoperative details. Whether what type of fluids were given during surgery, before surgery, whether any fluids were given, during surgery, how much of fluids are given, suppose whether the anesthetist has given any nephrotoxic drugs during surgery, how was the bleeding during surgery, whether the bleeding was excessive, whether and how much is the estimated blood loss, and how was it managed, whether so that all I would like to see in the preoperative and intraoperative notes. Then whether the surgeon surgical team who has done the case, whether they got any suspicion of injury to the bladder, any hematoma during surgery. So all these things I would like to check in the operative notes. Now the preoperative details, I would like to know whether why the cesarean was delayed, and what fluids were given, if it is why it was delayed, and what was the fluid given, and whether they maintained the hydration by giving any fluids, whether fluids were given or not. Any preoperative, I'll look for any preoperative kidney function test, whether because to know whether she has any kidney problem before, and also whether they have charted the intake output chart. And also I would like to check whether she had any fever, any prolonged leaking, or any other renal problem, and how was her antenatal period. And so here the cesarean is done for the D18 with preeclampsia. So during cesarean section, the estimated blood loss is 1300 ml. But no blood transfusion was given, and she was managed medically with oxytocin only. So I would like to know whether any injury, how much fluids were given, and post-operatively whether the non-steroidal anti-inflammatory agents, that is the nephrotoxic drugs, whether they were stopped, and what is the how much of the fluids are given in the post-operative period. So this way I will look for the factors responsible. So now from the information given, the factors responsible could be for this acute kidney injury could be delay. First thing is delay in cesarean section. So lack of hydration, that's one thing. Second thing, preeclampsia, because she has preeclampsia, that itself decreases the renal blood flow. Third thing is estimated blood loss during cesarean section also added to it. She had a 1300 ml of blood loss. That will add to this problem. And then the other thing, fourth thing is she is carrying a twin pregnancy. So twins causes obstruction to the flow. That could be one reason. And I will rule out any nephrotoxic drugs which also can cause and sepsis. So these are the factors responsible for acute kidney injury. Now he will ask you then the other question is how will you follow up? So we follow, and so here I would like to debrief the patient about the situation. Follow up is arranged with the gynec team, renal team, and later on she can go with the GP, and then BP monitoring should be done in the community. Once she is stabilized and discharged, BP's monitoring will be monitoring in the community. Her hemoglobin will be corrected with the anemia correction will be done with the iron supplementation. Then I will do the instant reporting. That is coming to the clinical governance. I will do the instant reporting. Then I would like to involve the patient and her relatives. I will debrief them about what has happened. I will document everything what has been done. I will document, debrief the patient, and do the reflective practice, and then risk instant reporting and risk management. So this way, I will do the follow up of this patient. So then, how will you then coming to the prevention? He will ask you, how do you prevent the recurrence? So then we will say, there should any such case. If suppose any such case comes, we should not delay the cesarean section, a planned cesarean section, and there should not be any delay. And if there is any delay due to any reason, the adequate hydration should be maintained. We should take care of the hydration, and this is in the preoperative state. And intraoperatively, adequate fluid replacement should be given. Intake output chart should be there in strict monitoring and during surgery and post-operative period. And if there is any blood loss, excessive blood loss, it should be adequate replacement of the blood. And so post-operatively also, we need to continue monitoring her, and adequate fluid will be given, and avoiding the nephrotoxins. So this way, I would like to prevent the recurrence. Thank you for your time. So this is